Good evening, everybody. Thank you for joining us. My name is Ferry, and I'll be your moderator tonight for our live webinar through AO Sports America, How I Treat a Massive Rotator Cuff Tear. Some of our disclosures for AO North America. AO North America is an independent nonprofit surgical specialty society. We do not endorse or promote the use of any specific product and used in this course for demonstration purposes. So most people are familiar with AO, primarily starting obviously with the trauma. Very familiar with AO trauma. There's also AO recons. There's multiple different subspecialties in AO in general. AO Sports is an initiative that we kicked off about 2 years ago now to try and discuss more of the conditions that we're treating in the sports world. This is obviously the shoulder-based one, but we're also doing arthroscopy, general sports medicine, and knee as well. So we had our first webinar back in October 2020. So we really kicked this off right in the middle of the pandemic. Started off talking about the long head of the biceps. That was our first webinar. Second webinar, we then followed up the next month in November, talking about rotator cuff injuries. And then finally, our third webinar was in December of 2017, where we discussed glenohumeral instability. These were excellent educational activities with lots of good educational content and cases. You can refer back to the AO website if you want to see any of these. These webinars are on the website if you are interested. I'm happy to discuss that our next step in the shoulder curriculum is actually a live course. Right now, we have a master's course scheduled for March 4th and 5th of this year in Raynham, Massachusetts. We have a phenomenal international faculty from all over the UK, Germany, and also multiple places in the United States. If you're interested or want to learn more about this, if you see the link at the bottom of the page, take a screenshot or a picture with your phone, and that will get you to the registration page for the course in March. So the agenda for this course, it's a small group discussion. So really just have a couple of the participants with a couple faculty, primarily talking about cases, going through what we're doing, how we're doing it, and really staying based on literature. We're going to be discussing anterior glenohumeral instability, SLAP lesions and biceps injuries, rotator cuff tears, and then having a good spirited open discussion between the faculty, the panelists, and the participants. Everybody really have an open discussion. On day 2, we'll spend the whole day in the lab. So it's a hands-on cadaveric lab. So there'll be faculty-led stations, and we'll go through Bankart repairs, SLAP repairs, rotator cuff repairs, and then have the opportunity to an open lateral J or other type of open surgeries if you'd like. So why should you attend this course? Well, small group discussion. So it really fosters a small group discussion where we can get together and talk in a meaningful way. And there's also international thought leaders in shoulder surgery. We're all going to be together and can all help with the educational activity. There's going to be a hands-on cadaver lab, help you either learn new procedures or improve some of your existing skill set. And there's additional time for open procedures and dissections on the lab day. Plus, there's the opportunity to earn 14.25 CME credits. So that's always a nice thing to have after lab. Again, there's your link. If you're interested, please check it out, sign up. I'm happy to say that if you register before the end of the month, there is a discount to the registration fee. So hopefully that will encourage you to visit the site and sign up. So without further ado, my name is Ferry. I am in Arizona, sports surgeon, primarily doing shoulder, but also do some knee. With our faculty, this is also the faculty for the course in Raynham. The 4 of the faculty that will be there. Dr. Paul Favorito, he's the chief at Christ Hospital in Cincinnati, Ohio. Dr. Sharif Bishai, he is in the Detroit area in Michigan. And Brent Ponce, he is down at the Houston Clinic in Columbus, Georgia. So myself, Dr. Favorito, Dr. Bishai will be giving cases. Dr. Ponce will be manning the question and answer. So disclosures, if you need them, learning objectives. So through this webinar, we want you to be able to recognize the indications for more advanced procedures in patients with sports and soft tissue related pathologies of the shoulder. We want you to be able to learn how to describe the key steps in selected techniques for procedures like the superior capsular reconstruction or SCR, lower trapezius transfer, and other techniques we'll be discussing during this webinar. We also want you to be able to identify strategies to enhance the patient outcome and prevent complications. So the plan is, we're doing the welcome now. We'll have a case presented by Dr. Favorito. followed by a faculty discussion. Case 2 by Dr. Bishai, and I'll present a case if there's time. And then we'll have some time for participant question and answers at the end. We'll have a few minutes just to wrap up as well. So Zoom etiquette, please keep your microphones and your videos off. If you have questions, we encourage you to engage us. You're going to do that by going through the question and answer box at the bottom of the screen. So send in question and answer. Dr. Ponce is going to be monitoring that. For some of these, he'll reply right away with an answer. If there's some question he thinks are going to stimulate a good conversation at the end of the case, as we switch over between presenters, we'll have a time to go through a couple questions, and then whatever's left over at the end in the wrap-up. All right, so we can switch over to Dr. Favorito and his talk.
All right, Eamon, thank you so much for that introduction. I'm going to talk a little bit about lower trapezius transfer for rotator cuff tears. Here are my disclosures. So when we think about posterior-superior rotator cuff tears, we know that not all of them are repairable, and irreparability is correlated with certain structural things, such as massive tears, where we have 2 or more tendons, fatty atrophy, Goutallier 3 and 4 changes, substantial retraction to the level of the glenoid or even further medially, and then proximal humeral migration. And when we think about the treatment options for these very large posterior-superior tears, we can treat them non-operatively. Some patients will do well with simple things such as physical therapy and activity modification. We can try arthroscopy with debridement with or without partial repair. Superior capsule reconstruction has become very in vogue recently. Reverse shoulder arthroplasty works well. And also tendon transfers. In the past, that had been popularized by like Christian Gerber, the latissimus dorsi transfer, and more commonly by Bassam-Elissan, the lower trapezius transfer. And that's what we're going to discuss primarily tonight. So when we think about trapezius anatomy, we know where the trapezius is, but a little anatomy review is sometimes helpful. It originates very far proximally, almost to the occiput along the cervical spine, and then all the way down to T12. When we look at the insertion, we have the upper fibers on the lateral third of the clavicle, the medial fibers on the posterior scapular spine, and then, of course, the lower fibers and the inframedial scapular spine. We know the innervation is spinal accessory nerve, which is a few centimeters medial to the medial border of the scapula. So why should we consider the lower trapezius transfer? Well, it is a fairly simple transfer. The tendon's short, so it requires an extension graft. It can be done arthroscopically assisted. It allows better restoration of shoulder biomechanics. And the line of pull of the lower trap really closely mimics the infraspinatus muscle and tendon. It's pretty easy to train this transfer. It's what we call an in-phase transfer because the trapezius, and especially the lower trapezius, contracts during external rotation of the shoulder. And if there's any subscapularis pathology, it's not a contraindication to the transfer. And when we go back maybe to our hand rotations or the principles of tendon transfer, we know that the transferred and recipient muscles should have similar excursion and tension. The transferred muscle should be expendable. The transfer and recipient tendon should have a similar line of pull. We've already discussed that. And then the transferred muscle should really only replace one function of the recipient muscle. So Bassam-Elissan, when he was at the Mayo Clinic, now he's in Boston, but he originally described this transfer for the paralytic shoulder, and that was more for either trauma or obstetrical injury. And what they found was a significant improvement in external rotation, but not as great improvements in abduction and flexion or forward elevation. When we look at the surgical anatomy of the lower trapezius tendon, this was some work done that really demonstrated very nicely that there's an anatomically distinct insertion site for the lower trapezius. And it inserts on the scapular spine dorsum. Now, the middle trapezius is more broadly along the superior surface of the scapular spine, but it's very easy. Once you know where it is, it's not difficult to find the insertion for the lower trap. You can really very easily find it without damaging the middle trapezius, and it's kind of muscle splitting. So you just have to know where the spinal accessory nerve is so that you don't damage it. So let me go through a case for you. So this is a patient that I've taken care of. He's a 51-year-old right-hand dominant male carpenter. He injured his left shoulder a few weeks before seeing me, but I think he had had some symptoms for a while. He had persistent pain, limited motion, couldn't return to work. So here we see his x-rays, a little bit of superior humeral head migration, but not too much. When we look at his MRI, what we see is a very, very large supraspinatus tear, narrow to acromial-humeral distance. The infraspinatus is also torn. The anterior side looks okay. Here we start to see the large infraspinatus tear. There it is right there. And then when we look on the on the sagittal images, pay close attention here. We want to see just how bad his infraspinatus and actually his teres look as well. We'll scroll back through those, but you'll see the quality of that muscle is very bad. So here's the unaffected right arm, and we see his left arm. He really uses triceps and elbow extension there. Here he is trying to raise his arm, no problem with the right side, but on the left side, he has really very poor forward elevation. So certainly not optimal. When we look at his external rotation lag test, no problem on the right, but on the left, you'll see that his arm goes back in, and he's basically saying to me, listen, I can't do that. And so, so when we think about our options, what could we do here? Primary arthroscopic or open repair. I didn't think that was possible. Primary open repair with augmentation. Again, just didn't feel like that repair was going to be successful. Tendon transfer or some sort of combined procedure. So I'll show you what we did here. And so here's the setup. We have to have him well medial on the table there. Here's the view from laterally. We see a very, very large, but probably repairable supraspinatus. But we know that from the MRI, the infraspinatus was likely not repairable. So in this case, I'm going to choose a combined procedure, which I don't usually do. I've done it a few times, but here we're going to do the combined procedure. So first things first, let's see if we can repair his supraspinatus. And so we'll place anchors along the medial row or the medial portion of the, just adjacent to the articular surface, and we'll pass those sutures. And then we're going to place another anchor far posteriorly, and that anchor is going to help us later with the lower trapezius transfer. And so now let's go to the open portion of the procedure. And so you see where the scapular spine is marked out. We'll make an incision a few centimeters below that. And this is a bigger man. He has very thick skin. There's always a layer of fat here that overlies that muscle. And so what we're looking to do here is find the muscle and the fascia. And so here we find the lower border of the trapezius. Once we find that, then we can follow the tendon to its insertion on the scapular spine. So here we are, we can see the inferior border of the tendinous fibers, and we're just going to extend that up. And so what we're doing is separating between the infraspinatus and the lower trapezius tendon. We'll create that plane carefully there, making sure not to damage the nerve. And then we'll peel the tendon off of the scapular spine. So there's the very short tendon, but we know that there's a very large muscle to which it attaches. So I usually put a traction suture in this and do a tiny bit of mobilization, mainly between the skin, and there it is. So now we've got a good mobile muscle and tendon unit. And so the next part of this is preparing the graft. So my physician's assistant has been preparing the graft while I was harvesting the tendon. And we just put a series of sutures into this, and we'll use those for later reattachment. So here's what we're going to do. We'll place a large clamp. He's a very large man. So in this case, we're going to do a two-step pass. So I take a very large curved Coker clamp, and we will find the interval between the deltoid and the rotator cuff, and we'll retrieve the sutures from the graft. And so we're going to pull those sutures in through the posterior portion of the incision. Then I'm going to transfer those to the anterior part of the wound. And so here we have the sutures from the graft coming in, and there is our Achilles allograft. And so what we'll do is we will take those sutures that I had previously placed in the anchor. We'll try to pass those around the graft, and those will help with what I call the right angle turn of this. So, so there are the sutures. I'm now looking anteriorly. The biceps is in the front. So I'm going to use, in this case, a knotless self-punching anchor laterally. And so this makes it very easy for us because we can incorporate the sutures from the graft into the anchor. And then we'll deploy the anchor, and we're fixing that tendon now to the most anterior portion of the greater tuberosity. And then we'll just take the remaining sutures and do that again. So here we have the graft should be pretty securely fixed anteriorly. And so I feel pretty good about that fixation. And now what we'll do is go back to the rotator cuff repair. First, we're going to retrieve those sutures from the anchor. Those go around the graft, and those will hold it in place. We can incorporate those sutures into an anchor, and that's going to confirm and make sure that that graft makes that quality right angle turn, and will essentially recreate the infraspinatus tendon. Fortunately, we have already passed the sutures for the supraspinatus portion of the repair. So I will tie those sutures, and then I'll pass them over the top of the graft, and I'll secure them again with a lateral row anchor. And so once we have all of our lateral rows complete, here we see our completed repair. So there's Achilles allograft, supraspinatus tendon. And so now we have everything secured on the arthroscopic side. Now we have to secure the allograft to the native tendon. And so what I do here is I will split the allograft into superior and inferior. I'll place a clamp through the musculotendinous junction of the lower trapezius, and I will pull that allograft tendon. And so what we're doing here is a modification of a pulver-taft typed weave. And so I make sure to externally rotate and abduct the arm, and then I will use a series of sutures, interrupted sutures, to tie and secure the graft to the native tendon. So when I've got the superior portion fixed, I will then take the inferior portion of that graft, and again, using a series of interrupted sutures, incorporate the graft to the residual muscle. And so it's a lot of suturing, and you'll see the position that the arm was in, abduction and maximum of external rotation. But here, when we bring the arm to a neutral position, there you see the new muscle tendon unit working as expected. If you don't see that at the end of the operation, it's concerning. Now, I'll keep them in an external rotation brace in about 10 to 15 degrees of external rotation for a full 6 weeks post-operatively. And so here's his result at 5 months. He went from having less than 90 degrees of forward elevation. He now has active external rotation. And there's my PA demonstrating what sort of resistance he has. So he has now active abduction. And as far as he's concerned, he has a substantially more functional arm than he did preoperatively. And so there is data out here. Here's Bassem El-Hassan's work from 2016, 33 patients, average follow-up of a little over 4 years, or right around 4 years. And what they found were significant improvements in pain, subjective shoulder value, DASH scores, and range of motion also substantially improved. Here's some work that was done by Philippe Valenti out of France, 14 patients, irreparable tears. And these, in France, they don't use as much allograft. So he, instead of using Achilles, used semitendinosus autograft. Some of these patients also had latissimus transfers. But the bottom line is they went from minus 20 degrees of external rotation to 24 degrees, so an almost 40 plus degree improvement. External rotation in abduction minus 10 to 40, and forward elevation improved as well. Again, improvements in subjective shoulder or patient-reported outcomes. And so unfortunately, 2 operations for hematoma at the harvest site and 1 with an infection. Here's some work done by Serena Namdari out of the Rothman side, 15 patients, average age of 52, minimum follow-up of 12 months. 3 of 15 converted to reverse, but the 12 that were not had significant improvements in validated outcome scores and improvements in range of motion. Most specifically, there is some improvement in the flexion in all of these, but really what's noticeable is the external rotation. Here, 60 degrees of improvement there. And this is a meta-analysis just looking in general at the lower trapezius transfer, biomechanical data, techniques, clinical outcomes. They reviewed 18 studies, and these compared latissimus dorsi to lower trap. And what they found was that there's biomechanical data suggesting that the lower trapezius is a better transfer. Technically, you can do this several ways, both open and arthroscopically, with autograft or allograft. And clinically, we see significant improvements in shoulder function, and that includes range of motion and functional outcome scores. So their conclusion is that the lower trapezius transfer is generally safe. Clinical and biomechanical data support the use of this to restore function in what is traditionally be considered a very challenging patient population. So thank you very much.
Great, Paul, great case. Very nice presentation. Thank you for that. Question. So what if the patient has the tear extending into the subscapularis? Is that, obviously you demonstrated a big posterior superior cuff, but if there's anterior extension, does that change your thought process?
So, the way I think about the shoulders, I want it to be balanced as well as possible. And so one of the challenges with a latissimus dorsi transfer is that any subscapularis pathology was a contraindication of doing this. So what I found is that most subscapularis tears are repairable. And so if I have an upper third tear and even upper 50%, I'll fix it. If the biceps is a problem, I will tenodese that as well. So I think about trying to eliminate the pain generators and then generally improving function. And how do we do that? Balance the shoulder. So fix the subscap. So we have anterior, well-functioning muscle tendon unit, and then posteriorly, we're balancing that with this new transfer.
Perfect. Yeah. Brent, did you have any questions from the audience for us to go through?
Yes, it helps to turn the mute off. So the first question that came up was the role of the arthroscopy portion. And that question came before you did the video presentation. And just to clarify, it seems like you used the arthroscopy both to diagnose what can be fixed, but then also to facilitate the placement of the anchors for the transfer. Correct.
So, so in this particular case, I showed a rotator cuff tear and the transfer, but the majority of cases, the supraspinatus is not repairable. And in which case it actually makes this pretty easy. You look inside the shoulder, you have a massive irreparable rotator cuff tear. You prepare the greater tuberosity, and that can be either through just simple abrasion with a shaver or a burr. I usually do some microfracture. I place my anchors, and I usually place 3 anchors. So I'll place 3 medial anchors. And so everything's prepared on the inside. I'm all ready to go. And then I begin my, and then I'll basically just transfer the tendon. It's really not that difficult. I mean, of course I have to harvest, but then you transfer the tendon and then you fix it. It's really not much different from doing a double row rotator cuff repair.
So Paul, tell us a little bit about your learning curve. Did you first go to the lab? Did you first try it on a patient? Did you first do it all open? Did you do it arthroscopically at time 0? Tell us a little bit about that learning curve and how long did it take you to transition?
Well, so I had been following this along for some time, and fortunately, I had been to some meetings, and I know Bassem El-Hassan, and so it was probably 2019, I think. I was in Chengdu, China, and he was presenting on this, and he was showing his results. And it was about the same time where I was sort of losing my enthusiasm for SCR because I just wasn't seeing the results that I was reading about. And I was thinking, like my results, my arthroscopic endpoint is good, but I'm just not seeing it clinically. So I talked to Bassem about this, and he said, you have to start doing this. And I was like, okay. And so I'm also fortunate to teach a lot of labs, and I usually teach Latarjet labs where they almost always have a torso. And so when everyone is done doing the Latarjet portion of the lab, I started harvesting and learning to understand the anatomy of the trapezius because look, let's be honest, this is not a place where we spend a lot of time. When people say, where's the trapezius insert? If I ask them, they're like, there's like around the clavicle, right? Because that's what we're familiar with, fixing a clavicle fracture. But the lower trapezius, we don't have any experience there. So I would tell you that I spent some time understanding where it was. And that case that I showed you was actually my very first case. That was the first one I ever did. I've probably done 10 or 15 since then, and I've been shocked at how good the results have been compared to SCR. So my indication for an SCR is remarkably narrow right now. But what I would say to anyone is if you're going to do this, you need to go to the lab at least once and understand where the anatomy is, because I think this is not, you don't want to harvest this for the first time on your first patient. The arthroscopic work is not that difficult. Really, it isn't. It's actually pretty easy.
Point well taken. That's a nice plug for the upcoming lab. At the same time, it's nice
absolutely.
opportunity to transition to the next talk.
Absolutely.
So while we're working through this, we got another question here. How do you adjust the tension when you suture the graft to the lower trapezius? Paul?
So the tension is set when after the graft has been secured to the greater tuberosity, I will then maximally externally rotate the arm. So just like I showed in the video, all the way out and a little bit of abduction. And so then when I pass that tendon, the graft through the muscle, I pull it back upon itself, and I pull it so that there's a reasonable amount of tension on that. Not so much that you're going to pull it through, but there should be some very, very good tension on that. And then I suture it in that position. And so the ultimate test as to whether you have that correct is when you take the arm out of external rotation and bring it back, you want to make sure that the muscle tendon unit is moving when the arm is passively rotated.
Yeah, that's a great point. You really feel good about it.
Yep.
I mean, you feel really good about it when you internally, externally rotate that arm after you've sutured it in. You can see the muscle moving it, like in your video. It looks really.
Yep.
Perfect. All right, Sharif, you ready to go?
Yeah, everything look okay for you?
Looks good.
All right. So my charge tonight is to also, how do I treat that massive rotator cuff tear with an irreparable supraspinatus? So Paul did a wonderful job of showing us when you have at least an irreparable infra with a lag sign and significant weakness in external rotation. But what if you still have an infra or a repairable infra? So that brings us to what our learning objectives here. It's like we want to differentiate what is repairable, what is irreparable, and consider different options for it, as well as what techniques we can offer to our patients. Which brings us to our first poll question. So let's put it up and see what everyone would do. So what is your preferred treatment for the 50-year-old laborer with an irreparable supraspinatus tendon, but a repairable infraspinatus in the absence of glenohumeral arthritis? So we'll give you a couple seconds to put down what you'd do here. So here we go. So partial repair, arthroscopic growth, about 31%. Primary repair with augmentation. And this, again, that's an open repair. An STR in about 15, a tendon transfer, 18%, and reverse in 6%. So kind of a little bit all over the map here, which is good because it shows you that there are options for how to fix these. So let's move on. So our case today is a 59-year-old right-hand dominant laborer, right shoulder pain and weakness after a motor vehicle collision. He's had this pain for about 6 weeks. He started PT before he came to me. It's not helping. He had a mini open repair about 10 years ago. He says that the anti-inflammatories are not helping at all. He can't sleep. He has pain. He's requiring narcotics. And because I'm here in Detroit, he works on the line building cars at Henry Ford. So past medical histories, hypertension, diabetic, hypothyroidism, as well as a 1-pack per day smoker, and drinks about about 6 beers a day. So this is pretty much an average Detroit patient for me. So let's look at what's going on. So he only has about 7 degrees of forward flexion. Passively, I can get him to 140 degrees, external rotation to 45 degrees, abduction to 70, and can only get to his sacrum with internal rotation. You can see significant weakness of supra and infra. He's got a positive knee, positive Hawkins, negative cross arm, but he does have a hornblowers, negative bear hug, positive Job, positive shrug. So, and although he does have a hornblowers, he has a true negative lag sign with the arm internally rotated slightly past neutral. He is able to give me some strength. So I know that infra or teres has some strength still. So his x-rays are here, shows a little bit of arthritis, a little bit of superior migration. He still is centered, although he has a little bit of a retroverted glenoid. But, you know, he is unfortunately in a position that a reverse total shoulder arthroplasty is not an option for him. That would be a career ender for him. So what advanced imaging would we get? And if so, what? So MRI, obviously, and you can see some old anchors from his previous repair. You can see literally no cuff for supra. You can't even really see where it is on the glenoid. You do see some infraspinatus here. You do see some subscap. So, and then I call this the male pattern baldness head, which is a little bit of supra and infra, but, or excuse me, a little bit of subscap and infra, but supra is gone. So again, Gutalier changes we need to address. You can see with the tangential line that that muscle is below it. So right there, that's a poor indicator of the supra being repairable. Infra does have some streaking. And so, you know, just like for those that eat meat, we want to eat something more toward the left and less to the right. So we want to make sure that when we look at these types of MRIs, it's as though we're at the butcher shop. Which one would we want? And now that we can understand, is this tear even repairable? Probably not. What is the importance here of this type of injury, and what treatment options do we have? So in this particular case, it appears that if the infra does have a tear, it did look a little bit thin. It looks repairable, but the supra does not. So Paul went through some of these and very similar, menu here: debridement, tenotomy, and rehab. Obviously conservative, partial repair with some sort of augmentation or scaffold, some sort of interposition, SCR, subacromial spacer like a balloon, some sort of transfer, or even a reverse. So when we look here, it's important to really understand what is the superior capsule. So you can see here, there's two parts to the cuff. There's actually 5 layers. So the layer you're pulling on there is layers essentially 1 through 4, but layer 5 is this thick capsule that actually aligns with the articular margin. So you got to be careful not to try to grab this piece here and get it all the way lateral. You have to make sure that that is going to be along the articular margin. Otherwise, you'll overtension and then likely have a type 2 failure at the myotendinous junction later on. But with the SCR, this is going to prevent that superior migration of the humeral head. And therefore, if we can restore the force couple, we may be able to get some sort of forward flexion and some sort of supraspinatus type motion. And this is what Mahata learned back in 2014 when he originally discussed this. He said that with the superior capsule, it's about 4 to 9 millimeters thick, it covers about 30 to 60% of our greater tuberosity. Without it, our humeral translation increases in all planes. So if he could reconstruct the superior capsule, and then this would prevent this superior translation and decrease the subacromial contact pressures. At the same time, we got to make sure that we're not arthritic. So we want to make sure that we're within stage 1 or 2 here if we're going to discuss having this type of procedure. But once we start getting further along with stages 3 through 5, we may not be able to offer this type of procedure to the patient. We may have to go to some type of arthroplasty procedure. So here you can see our goal is to implant it into the glenoid, essentially drape the humeral head with it, and then anchor it laterally, again, pushing that humeral head down and essentially restoring a force couple by way of a dermal allograft, at least in the States, but in Japan, utilizing a tensor fascial autograft. But you can see that with a supraspinatus tear versus superior capsule versus a tendon patch, what we want to do is decrease this translation. That's what we're seeing here with the superior capsule reconstruction. We're also seeing that our contact pressure significantly go down when we're able to push that humeral head down. So again, what about if we tried to do a debridement, a tenotomy, maybe rehab, just essentially a cleanup of that shoulder? Problem is we have failure rates of upwards of 52%. So most patients aren't going to decide that they want this type of procedure with the flip of a coin. So, you know, the SCR does offer an excellent way to fix these types of procedures with this reconstruction, but it's really important that when you do a superior capsule reconstruction, it is not just laying that dermal allograft or a tensor fasciolata from the glenoid to the humerus, but you also have to tie it in with margin convergent sutures to the infraspinatus. Otherwise, you don't really push that humeral head down, and you can actually have that humeral head buttonhole through the SCR reconstruction and the infraspinatus, and therefore you haven't really decreased your contact pressure. So biomechanically, if you have a graft that's less than 4 millimeters, it really is not your best option. You want something thicker than at least 4 millimeters. 8 millimeter graft is what was used with a doubled over tensor fasciolata autograft. And this was able to be positioned between 15 and 45 degrees, which reversed the superior migration of the humeral head. So with these decreased subacromial contact pressure with a thicker graft, it allows for not only the acromial humeral distance to be increased, but it also continues to push that humeral head down. And we'll talk here in a second that with the thinner grafts, they elongate. And so if you have a graft that's less than 4 millimeters, it's not going to be 4 millimeters for long. It's actually going to get thinner over time and probably be about 2 to 3 millimeters. And so sometimes when we are discussing the outcomes with this, which we'll talk about in a second, we got to take into consideration what we're using, because if you have a thicker graft, it's less likely to elongate. So in this particular case, you can see here, we can see the infraspinatus here to the right of the screen. We're putting our posterior anchor here, putting our anterior anchor here. We've cleaned up our tuberosity. You can see that we positioned our glenoid anchors there as well. We're going to measure this, measure the length, the distance. Then we want to go with whatever we measured. We want to go about 5 millimeters bigger than this in all sides. And now essentially just going to pull that in to the glenoid. We have our sutures already parked medially. We're going to tie those down on the medial side. So now this is attached to the glenoid. Now we're going to grab some of the sutures we already had, and some of it, we're going to place it through the infraspinatus. We're going to grab this tissue, and now we're going to pass some of the tissues through, or the suture through it as well. This is essentially just like a rotator cuff repair. This is a retrograde way to do it. It's actually easier if you're not going to pass your sutures outside the body to do it with the retrograde passer like this, because this tissue you can see is very thick, and so sometimes the automatic suture passers that most companies have, it makes it very difficult to pass because of the thickness of the tendon. The graft here, and you can see this particular graft is about 5 millimeters. Now we're going to pass the margin convergent suture through the infraspinatus, and this is essentially going to tie this into native tissue. And then once that's tied down, we'll be able to grab some of these other tissues, and essentially it's a rotator cuff repair from there, and essentially a suture bridge type repair. So we're going to pass one more margin convergence, really bring it down nicely. And for me, I like to position the arm in about 15 degrees of external rotation and about 45 degrees of abduction. I use a arm holder, and during that time, I actually will pull that arm down, essentially trying to get that head as low as I can go. So at the time that I finally fixate the lateral side after this microfracture, then I'll make sure that it is going to hold it in place, trying to restore that force couple. You can see one stitch here in the interval, and then we're going to finally pass with the remaining sutures laterally. We're going to bring those over and fixate the lateral side. Again, this is a self-punching anchor here. This is a dynamic suture, so I know it's going to continue to compress after I continue and put the lateral anchor in. And then once we're done here, we got one more anchor posteriorly, and we'll have our finished construct, and you can see that humeral head is covered. And so here comes the last self-punching anchor, and then we're going to tension it one last time. And then once that's completed, I'll show you the finished product. And so there's the finished product. So we got good head coverage. We've tied it into that infraspinatus. It moves as a unit, and now we're ready to move on. So you can see here the post-op imaging comparatively to the pre-op imaging. So you can see you got head coverage, a nice thick tissue and a graft there. Pre-op, you can see this particular gentleman over here is trying to lift that arm. Get the pseudo-paralytic type motion. You can see he's trying to elevate. You can see how that anterior deltoid is really firing to try to help him lift that arm. Versus post-operatively, he's able to take both arms and lift it up. And he's very happy with his outcome. He'll show you that he has a little bit of extra rotation as well. Maybe it got cut out, I apologize. So what does the literature show? So Mahata in 13 looked at this and found in his level 4 study, 23 patients, 24 shoulders. But again, we're going to talk about the graft being a tensor fasciolata of almost 8 millimeters. He had 83.3% that healed, but you can see that forward flexion went from 84 to 148 degrees. External rotation increased, likely because there was a repair of the infraspinatus as well. And the ASES score, you can see significantly increased from 23 to about 93. Hirahara looked at level 3 evidence with 8 patients. ASES scores from 43 to 86. But again, this is only 8 patients. This was an acellular dermal allograft of about 3 millimeters, and one was revised to a reverse, and one had a graft rupture. So again, this one maybe doesn't leave so much to be desired. Mahata in 18 looked at his first 100 patients, level 3, had a complication rate of about 16%, which were 5 graft failures. But again, the ASES scores went from 36 to 92, and you can see a significant increase here in forward flexion as well. Denard looked at this, 59 patients, level 4, using an acellular graft. Many of these patients already had decent forward flexion, but it went from 130 to 158. In his, the acromial-humeral interval was unchanged. 45% of theirs healed, but of this quote-unquote healed group, they did have better outcomes, which makes sense. Success was about 67%. 7 failures on the humeral side. Most people think that it happens on the glenoid, but it actually is more common to see these failures on the humeral side. 100% success rate in those that healed, again, but you gotta look back, that healed was only about 45%. Higher subscapularis atrophy had poor prognosis. Again, in Pennington's study, 86 patients, 88 shoulders, an ASES score that went from 52 to 82, VAS score that went down, a humeral interval that was increased, so shows that the humeral head is being depressed, and 90% were satisfied. And then Mahata 19, level 4 study, 30 patients, 5-year follow-up. At 5 years, a healed SCR restored the shoulder function, and it resulted in higher return to sport and work. And then in those that had a graft failure, they had severe cuff tear arthropathy that needed a reverse total shoulder arthroplasty. So I'll just point out a few things. The posterior side-to-side suture to the residual infraspinatus creates that posterior continuity and restores that superior stability of the glenohumeral joint. A graft should be secured somewhere about 10 to 30 degrees of abduction, 15 to 45 degrees of abduction, and 20 degrees of internal rotation. Again, performing an acromioplasty will decrease the subacromial contact area, again, raising that roof over the graft. And again, really understand your graft that you choose. If you use a 3 millimeter graft, it will elongate about 15%. So the thicker the graft, the better. So some technical tips: fix that SCR laterally with about 45 degrees of abduction. Really push down on that humeral head. If you have somebody helping you, have them pull down on the arm. If you're using some type of arm holding device, again, utilize that. The graft thickness, we again discussed that thicker is better. So their conclusions for 2022, what are indications? A younger active patient with a subscapularis that's intact or repairable, absence of osteoarthritis, absence of S-tabularization, external rotation that has some strength, and the patient will be compliant. The superior capsule is technically challenging, but may eventually lead to better outcomes for the patient. A dermal allograft, we want to have one that's thicker. Obviously, fix what you can. And primary repair is our first goal. So our take-home messages today, there's many ways to address these patients, as we saw with our poll initially. Treatment must be individualized for the best outcomes. And if you do choose to do an SCR, this intolerable pain and or unacceptable dysfunction with irreparable rotator cuff tear is definitely the type of patient you want to do it in, with a Hamada 1 or 2, and then an intact subscapularis and infraspinatus. Thank you.
So in the sake of time, Armin, how about if you go ahead and get your presentation up and we can ask Sharif questions now and at the end, time permitting. So while the transition's happening, over time, Sharif, tell us about your level of enthusiasm for the SCR. Paul talked about his, like a stock, it's selling, it's going down over time. How has your enthusiasm been since you first started doing this, become more proficient? You've tailored it. Is this something that's expanding in your practice, or is this something that's becoming more and more narrowly defined?
So it's becoming more narrowly defined. I think this is a static type reconstruction. So a dynamic type reconstruction, like a lower trapezius transfer, makes more sense. I think it affords at least I can even say to a patient, this might be the only procedure you get. Whereas an SCR, in many cases, I'm telling the patient this is a bridging type procedure, and eventually it will fail as that graft elongates, or if it even heals. So I will say that as he says that he is selling, I've sold. I have moved to a lower trapezius transfer. I think there is a small subset of patients that probably don't need a lower trap, and this would be suffice. But I think more often than not, once that super goes and it's irreparable, in many cases that infra has pathology. So to me, I've essentially started going more, if not completely, towards a lower trap.
So now with that, and Anand, if you're ready, you can go ahead and take it over. But with this, your bailout for a failed SCR, is it another SCR? Is it a balloon in a position arthroplasty? Is it an RSA? Is it a tendon transfer?
I think that you got to individualize that and really understand that infraspinatus and how much arthritis that patient has. So it's definitely not another SCR. You know, the definition of insanity is to do the same thing twice and expect a different outcome. So if it failed the first time, I'm not going to go that route. I will tell you that if a lower trapezius fails and you go to a reverse, you've actually given that patient external rotation with the reverse. They're going to gain their forward flexion because of the reverse, but they're also going to now have external rotation with the lower trapezius. So you actually built a bridge. You didn't burn a bridge when you do that lower trap.
Nice point. That's a really good point to consider. How we doing, Amon? Are you ready?
Good to go. Can you see my slides?
Yes, we can. Floor is yours.
All right. So keep this on. Let's make this somewhat interactive, kind of like a little panel discussion on my case here. So I've got a 52-year-old man. He's right-hand dominant. He's what we consider a rat. He comes to me with about a 3-month history of right shoulder pain, and he can identify the time when the pain started. It was an injury at work. He's a border patrol agent. He was training a dog. The dog jerked on the leash, and he felt the pop in his shoulder. Before then, he said he had no problems at all with his shoulder and was very active in the gym. On his physical examination, he's near full range of motion. I could get him a little bit further passively. He was a little hesitant to go full range of motion because of the pain. But he had no tenderness around the shoulder. He was weak with supraspinatus and infraspinatus testing, but no lag sign like you saw previously on the other cases. His subscapularis testing was normal, and he didn't have any signs of instability. So here's his MRI. You can see, it's a large rotator cuff tear here, primarily superior cuff. Looks like infraspinatus and subscapularis are pretty well preserved. And if you look at his muscle quality there, not really much fatty infiltration and not much atrophy. So we're thinking this is probably more on the acute side, like he mentions. He may have had a small partial tear, maybe a small full thickness tear, but I think a lot of this was probably acute, a lot of edema around the muscles. But as you see here on the MRI, he seems to have a pretty well balanced shoulder, kind of like Paul was talking earlier, where you have posterior and anterior cuff intact, and that's why he still has the function. So at this point, Brent, what do you think? Treatment options, therapy? Are we doing a cuff repair? Are we going to do this wonderful technique that we just saw from Paul, this trapezius transfer? Sharif showed us superior capsular reconstruction, which made it look so easy today, and saying, listen, we're not doing anything with this.
So I think you bring up a really good point here. And the key thing to me is two things. It's kind of redundant. One is he's age, so he's young and active. And the second thing, traumatic. I like the images that you showed, and it would have been nice to have seen a coronal view a little bit more on the medial aspect to see, is it that some of that atrophy that we saw was just really retraction, because it looked like the muscle quality was good without much fatty infiltration. So my thought on this would be early surgical intervention with a repair attempt, knowing that most likely the elasticity is good if he really did not have an acute on chronic condition.
Exactly. Paul, Sharif, you guys already showed us that SCR and lower trap. Would you want to do anything different for this guy so far?
As I look at, go ahead, Paul.
No, you go ahead, man.
I was just going to say, I would be prepared to try to fix this acutely, and if I can get it over and maybe do some type of augmentation, that'd be great. But I'd also be prepared at the same time to, it sounds like infra is intact, so this would be one of those patients that I think an SCR would suffice for them.
So what do you bring into the OR? You bring in grafts? I mean, if you are, what kind are you calling for?
So I would obviously have the traditional anchors and everything else that I'd use on either procedure. but then I'd also have a roughly a 5 to 6 millimeter dermal graft for the SCR if that was the route I went. But I'd also have some type of likely a synthetic or biologic or a combined graft to lay over this repair to help with healing.
So you're ready for everything. Paul, what about you?
Yeah, so when I look at this, I'm looking at this MRI, and I see some changes around the greater tuberosity, which I think are bony. And could you go back to the original X-rays? I just want to see that.
Didn't have X-rays, just MRI.
X-rays. Okay, yeah, okay. So, all right. So, so the changes that I see around the tuberosity suggest that there may have been some pre-existing changes, right? So when you ask these people if they had symptoms, they say no, but it doesn't mean they didn't have a small asymptomatic chronic tear. So I would be prepared here, even though his muscle is excellent in quality, negative tangent sign, Goutallier basically zero. He's got no fatty infiltration there at all, or no streaking. But I'd be prepared to have to do some additional things here. You're hoping for primary repair, but I would probably have some sort of extracellular matrix, whether that's bovine or dermal or something, because it would be nice to, you may have to add some biology here and hopefully some graft that will provide some load sharing while the tendon is healing. I'm not sure that I would go to SCR, but I would like to have something for the tendon.
So Paul, if you could not repair it, let's say, and that's the only reason I have SCR there, so I don't have, get caught with without having, what would you do if this was not a repairable tear?
Yeah, so I would have 2 grafts there, just like you. I would have the hopefully the 5 to 6 millimeter SCR dermal allograft, but I would also have maybe a 3 millimeter dermal allograft or some sort of extracellular matrix to augment my primary repair, assuming I could get it repaired.
Hey, real quick here, Paul, somebody asked the question about the thickest graft that's available commercially. And you said 5 to 6 millimeters. Which graft are you using? And I realize we're not supposed to be advocating, but if that's the thickest one, it does seem appropriate to mention it.
Yeah, so there are a few grafts, there are a few companies out there that make those. RTI is one of them, and I can usually get about a 5 millimeter graft out of them. And it is a thick graft. It gets your attention. Once you put it in, you better have all your ducks in a row because it really diminishes the acromiohumeral space pretty quickly. But yeah, there's at least 1 or 2 companies where I can usually get about a 5 millimeter graft.
Thank you.
All right, so it sounds like makes sense. This is, let's get in there. Let's take a look around, see what the cuff looks like, what the shoulder will give us, but be prepared for some augmentation. So got in there, and here's this viewing from the posterior lateral portal. You can see grabbing the tissue here. It's checking mobility. There's infra way back there, so that looks okay. Obviously a big supra, probably L configuration there. Pretty mobile. This is without me doing any type of work to release or anything. This is just getting in the shoulder and looking around. So Brent, at this point, what are you thinking about doing?
Thinking of doing 2-3 anchors medial and doing some type of double row configuration, and then possibly zipping up the supra and infra if you're concerned about possibly a gap, just to help share the load and offload some of the repair.
Great. Sharif, is this an SCR for you, or do you think you can fix it?
I think I agree 100% with Dr. Ponce. I think that this would be a repairable type tear. You have quite a bit of collagen with that biceps as well. You could incorporate that as well. And, there is new data to show that even just tenadesing that biceps, almost like an SCR, can really help keep that humeral head down. And there's good data on that. So you have that collagen right there, plus minus using something else on top of that repair. Now, if you can't, I noticed that when you pulled it over, it just got past that articular margin, but you did say you haven't done any particular releases, but let's say that's as far as you could go. I think you would just have to medialize that repair just slightly and maybe do some microfracture lateral to that. But I think that is definitely a repairable tear in my hands.
And that's a good point that Sharif brings up. You're able to medialize about 1 centimeter without really changing the dynamics of the shoulder. And if that's going to help reduce your tension, that's an important step. And that's been shown in 2 separate studies.
Yeah, so we talked about releases, and so that's what I did. So I start in the subacromial space, trying to release it off the acromion, kind of working my way anteriorly. You can see I had a traction suture in the back, so I have my assistant putting some traction on it. Just trying, especially if I see these tears that are, tracted more anteriorly, I will spend more time doing those releases anteriorly as they come along, releasing it, and we'll actually end up. Fast forward this just a bit in the interest of time into capsule, but then also doing that rotator interval. So for this, I want to get this more posteriorly. I want to get coverage. And so I have no problem releasing the rotator interval in these cases, really to get some more retractability of that cuff posteriorly, so I can get those anchors placed and get, you can see now I'm getting a little bit more, and I'll end up releasing even a little bit more anteriorly. There, you can go all the way down to the base of the coracoid. That'll give you definitely some more excursion there posteriorly.
And I like the move on these where once you're happy with how much excursion you're going to get, you use a traction stitch and then you zip up the L, and all of a sudden it becomes a really small tear because you're getting some relief from the infraspinatus holding it out laterally.
Exactly. No, that's a great point. So here, doing some margin convergence posteriorly. So start immediately, work my way laterally, and then you can see how that reduces the cuff without even putting an anchor into the graded tuberosity. So that's its resting spot right there. And you can see, I've cheated a little bit from the front, and I think Sharif makes a great point. I didn't do it in this case, but using that biceps as an augment, either tenodecing it and add it into your repair at the graded tuberosity, or even using it as a tenodesis effect can really help give you more stability and biology for fixation. So through my medial row anchors, like you guys are mentioning, doing a double row. For this, I felt I would augment with some allograft. And so these are the allograft pledgets. So these slide down over the sutures, and you can pass them through an anchor laterally. And I'll fast forward a little bit, I think. And you can see, just like was shown previously, placing those lateral anchors along the lateral aspect of the proximal humerus, and then tensioning them, cinching them down. Very nice and easy way to add a little allograft tissue to your repair. So that's the final construct: double row repair with some allograft over the top, margin convergent sutures. So post-operatively, I kept them in a sling for 6 weeks. Started physiotherapy at 4 weeks for passive range of motion and active assist. So I slowed him down a little bit. Usually I start these at 2 weeks, but with the size of his tear, and really give him a chance to get a little more healing in before he got in, and the physical therapist got a hold of him. Started him in active range of motion at 6 weeks, light strengthening at 12 weeks, return to full activity at 6 months. So how do you do? So at 6 weeks, predictable, limited range of motion, but at 12 weeks that returned to where he was preoperatively. I came back at 6 months, said he felt great, had a little pinching, typical findings you get after a rotator cuff repair, but had full range of motion, his strength good. He actually came back 18 months after surgery. He was doing great. He just needed me to fill out some paperwork for his workman's comp injury. He was back to full activity in his gym, and the guy's yoked. He was pretty unbelievable. So he was doing well and happy with the results. So take-home messages here. Identify your preoperative risk factors for fail. We talked about larger tears, and with the positioning of the tears. If there's a subscap tear that you can fix, that's going to factor into your decision-making process. And pre-op function, seeing what they can do, because that may help you. My guy had good function. If you don't have good function, then you may be more leaning towards a tendon transfer, something that's going to provide more functional results. It can restore the anatomy, fix the tear, consider an augment. If you can't, consider a SCR, lower trapezius transfer. Pros and cons for both. I think we laid those out nicely for you. So think about those as you're seeing a patient that has a tear that you can't fix. Of course, if there's arthritis, significant degenerative changes, HOTAs 3 through 5, like Sharif is showing, those are great candidates for reverse arthroplasty, fixing their tendon or trying an SCR is not going to get them to the finish line. And then really think about your post-operative rehabilitation protocol. Make sure it's appropriate. You're giving these cases time to heal, because these are bigger repairs and they need a little bit more time in the sling before you really start moving them. Again, from all the faculty, I thank you guys very much for your attention. And keep in mind, we do have this course in March. Early bird sign up for the month. There's the link if you like, and hopefully we will be able to see you all there. Thank you very much. Good night.
Thank you.